evening, everybody.
Good evening.
In our series of ISAWB STAR classes, we are continuing with our series of classes on airway equipment. Today we have got two very important topics lined up, and they will be taken by Dr. Kosturi Hoshen Bandyopadhyay, who has already taken one class, all of you are aware of. And we have another guest with us, Dr. Amit Shah, who joins us from Gujarat. And he's one of the leading experts of airway, is not only in India but all of Southeast Asia. And he is a regular feature in all airway conferences, all anesthesia conferences in general, and all airway conferences. None of the airway conferences are, complete without his presence. He and Dr. Apex Patwa, they sort of have a group, and they conduct airway workshops in their place and also in many other places. I remember last time they came here, we had a workshop on bariatric surgery, and they had live workshops. I was also part of it, so that's where I first met him. And not only that, he's a good teacher, he's also an inventor also. To his credit, they have developed a video laryngoscope which is called Patwa Shah. I think it was launched a couple of years ago, Dr. Shah. Hello? The Patwa Shahi video laryngoscope? I think 2 years.
Right now it is, yes. We have invented that, but right now we are still modifying it. So it is not right
modifying
now, but we are modifying it.
Okay, and also other devices like HFNO and something that you have.
Yes. That is this year
trying to prepare in this
invention. Yeah.
Okay. So he's also a very hands-on guy, good with instruments and all. So we're going to have an extremely interesting episode. So first we'll begin with on basic laryngoscopes, then we'll move to the Fibreoptic scopes or flexible scopes. So first we will have the question answer sessions at the end of it. All of you who are attending are sort of what should I say, used to these things. If you have any questions, please put it in the chat box, mark it as a question, and we will get back to your questions at the end of the session. So first, the laryngoscope will be taken by Dr. Kosturi Hoshen Bandyopadhyay, and she's a consultant at Medical Super Specialty Hospital in Kolkata. She's already taken a class. This is going to be a second class on this forum. So Kosturi, please take charge from now on.
Joyati, are my slides visible?
Not yet, ma'am. You have just shared your screen. You put up the slide now.
Yeah.
You just go to the PPT PowerPoint.
Okay, I'll go to the PPT PowerPoint. Right.
Yeah. Now you press the hide button and you click onto the slideshow button.
Right. Yes. Thank you so much. Thank you.
Welcome.
Okay. Is it visible
now?
Yeah, it is visible.
Yes, right.
Okay.
Perfect.
Thank you. Very good evening, everybody present in the room, and we are back with episode 6 of the ISA West Bengal conducted STAR classes, and it's a privilege to be here again. Today we are back with a very important tool from our armamentarium, the Laryngoscope. As far as exams are concerned, I'm sure every third or fourth candidate would be handed over this instrument on the Viva table. And as you are all aware, that this instrument plays a very integral role not only inside the operating theaters but also in the ER, in the critical care areas, as well as wherever the code blue team is present. This is one of the important part of airway management, the airway management armamentarium. Great. So since we all know that a laryngoscope helps us to see the larynx, so music cannot be far away. So the breakthrough to the throat came as a brainchild from the head of an opera singer, and he was none other than Manuel Garcia. He was the first person who looked into his throat while singing with the help of a mirror, and he did this indirectly. So therefore came the first invention of an indirect laryngoscope, and which became very popular, this technique, with otolaryngologists who use this technique in various ways to visualize the larynx and the vocal cord. This happened in 1854, and during that time, the people thought that it would be impossible to visualize the larynx because of its geometric disposition between the mouth and the larynx. However, one gentleman called Alfred Kirsten, he actually changed everything overnight. He proved people wrong and did the first direct examination of the interior of the larynx in 1895, and he demonstrated this at Berlin. Until then, as I said, that they were all practicing with indirect laryngoscopy, and this gentleman, he actually designed an instrument which he called an otoscope. It was a combination of an esophagoscope and an electroscope, and he not only designed this instrument, he also showed the technique of laryngoscopy and laid down certain principles which we still follow in clinical practice. If you see this picture of him doing the laryngoscopy, note that he has held the laryngoscope with the left hand, and just please note the position of the patient's head. So with the introduction of a direct laryngoscopy, he did give an introduction to the positions, to the holding, and so on and so forth. Right. So what is actually a laryngoscope? It's an instrument, as we all know, to visualize the larynx and the surrounding structures, either by displacing the soft tissue away from the line of vision or by optical aids. And the main purpose of a laryngoscope is to aid intubation. So how did we come to the present status of the laryngoscope? After Kirsten's discovery of a direct laryngoscopy, it was very well taken up again by otolaryngologists, and they started designing laryngoscopes with straight blades. Cavalier Jackson is one of them who actually designed a laryngoscope which had a U-shaped handle, a straight blade, and an O-shaped flange. Then came Janeway's L-shaped laryngoscope with a straight blade and batteries within the handle. This was again one step ahead, where the batteries were placed inside the handles, and they were the source of the energy to which the laryngoscope will light up. However, it is Robert A. Miller who presently introduced the laryngoscope, one of them of whom we are completely dependent on for pediatric anesthesia practice. But however, he introduced it for adult use. He never introduced it for pediatric use. We later on modified it for pediatric use another about 4 to 5 years later. So then came, however, Miller, when he saw the previous laryngoscopes which were used by the otolaryngologist, he understood that he needed modification. And these laryngoscopes which were used earlier had very small in length, and they had a very broad base, so that caused more dental injury, and visualization of the larynx was difficult. A relief came again once more, 1943, when Sir Robert Macintosh introduced his curved blade, and he demonstrated visualization of the larynx by indirectly elevating the epiglottis. Great. So if we try to classify the laryngoscope, it can be classified in rigid and flexible. The flexible fiber-optic bronchoscope and the flexible laryngoscopies, they will be dealt by none other than the stalwart Dr. Amit Shah. I will be talking primarily on the direct and indirect versions. And amongst the indirect versions, again, the video laryngoscope has been dealt and has been taught marvelously by Dr. Patwa last week. So we go ahead with the direct and the indirect laryngoscope one by one. So essentially, there are three parts to any laryngoscope. A detachable blade, it helps to elevate the lower jaw, move the tongue away from the path. A handle to apply suitable leverage to the blade and also to provide the energy source to the blade. The fitting or the joint, which is a fitting between the handle and the blade. So if we come to each part and break down into subparts, we will see that, and mind you, for the postgraduate trainees, you will be asked the parts, okay, and the specific function of each part. So you should at least know one function of each part. So we have the base, the heel, the tongue or the spatula, the web, the flange, the light, and the tip of the tongue. That is called the tip. So one is the curved blade and one is a straight blade. I'll come to that later on. So the base attaches to the handle, has a slot for engaging the hinge pin of the handle. The heel is the proximal end of the base and it contains a small metal ball that provides contact for the handle. And as soon as the contact is made, the circuit is completed and the laryngoscope is lighted up and it is ready for use. The spatula or the tongue is the main shaft. Now, this swipes away the tongue and depresses the lower jaw. Therefore, it clears a line of vision up to the larynx. And the long axis of the spatula is the basis on which we classify our straight blade and the curved blade. The flange, again, is parallel to the tongue or the spatula and serves as a guide to instrumentation and deflects the interfering tissue. The web. The web is the portion of the blade that connects the tongue and the flange. So the web is a vertical part. So the flange, the web, and the tongue, they constitute the cross section of the blade. So whenever we describe a blade, we need to talk about its cross section. And these are the three which constitute the cross section. The tip. The tip comes in contact with either the epiglottis or the vallicular, depending on what type of blade you're using. And so it directly or indirectly elevates the epiglottis and it is blunt and thickened to decrease trauma. The light source, again, is a bulb which is screwed onto the blade. Now, the electrical conduit runs at the back of the blade, and the light source may be either placed at the tip of the blade or in the base of the blade. The light source is usually an incandescent bulb, or it may be a fiber optic channel with an halogen or a xenon bulb. Coming to the handle, it is available in several sizes and types, as you will appreciate in this picture. It has a rough surface for better grip, accepts blade that needs metallic contact to light the bulb. Handles may contain batteries or circuits for fiber optic illumination. Fiber optic handles are called green line handles. They have these green bands here. And there are two specific types of handles you will see. These narrow ones are called the pencil handles, very useful in pediatric patients. And these fat and stout ones are called the stubby handles, again, very useful and handy in patients who are obese, women with large breasts, where you are using cricoid pressure, etc. Right, so this fitting between the handle and the blade, now this angulation can be changed by a special adapter called a Howland's lock. So you can add an Howland's lock on any conventional laryngoscope and it can reduce the blade angle to 45 degrees. As far as the light is concerned, so there is this ball on the blade is for contact. So as soon as it comes in contact with the slot on the handle, the circuit is completed and the bulb lights on. So this light also has been standardized. The minimal illumination standard for a laryngoscope light is 700 lux at a distance of 20 millimeter. So this is quite a bright light. This has already been standardized. The connection point between the handle and the blade. So there are two types of fitting that we usually get in our laryngoscopes. One is the hook-on type, which is the most common, and one is the pin type of fitting. The pin fits through holes in the blade and the handle. As I mentioned, the adapter can be fitted between the handle and the blade to allow the angle to be altered. However, most blades form a right angle with the handle when it is ready for use. It is acute. Examples of acute angle blades are as in Guidall and Bennett's blades, and obtuse angle as in Polio and Bowen-Jackson blades. Coming to a specific handle, the Patil Syracuse handle. It is an adjustable handle, if you see, and it actually allows the blade to lock in 4 different angles. So at 45, 90, 135 and 180. So the blades will lock at different angles according to the need. There is another blade called the Polio blade. It is given quite often in the exams. As you can ascertain from the name Polio, it was actually of great use when the polio patients were on external respirators or jackets, respirator jackets or body jackets. So they have an angulation of 135 degrees. Presently, they are very useful in patients who have short neck, who are obese, women with large breasts, those with kyphoscoliosis, those with barrel chest, and another very common problem when once the anesthesia screen is on, okay, and you are trying to intubate, it is very handy, the Polio blade. So we come to the curved variety of the blade or Macintosh blade. It is one of the most popular blades that we use, and the tongue has a gentle curve up to the tip. If you see this is a gentle curve up to the tip. If you see the cross section, as I said, the web, the flange and the tongue, it forms the cross section. Here it is a reverse Z. The tip is positioned in the vallicular. So this is what Macintosh did. He showed us the indirect way of lifting the epiglottis. So vallicular, as you know, is the cul-de-sac between the posterior part of the tongue and the epiglottis. So the tip lies at the vallicular and we lift the epiglottis. Size ranges from 1 to 4 and most adults require a size 3. What do we know about left-handed blade? Left-handed blade, it is actually just a mirror image of the right-handed blades, and it is primarily of use if you are intubating a patient in the right lateral decubitus position, or if there are severe fascio-maxillary abnormality in the right side of the face. So you have to use a left-handed blade and take the tongue to the left side of the mouth. Right, so there are some varieties about the Macintosh blade. If you see this, look at the flange. It is deficient here in the proximal part of the blade. So this is called the reduced flange Macintosh blade, useful for reducing dental injuries. Very useful if you are doing a laryngoscopy in patients with buck tooth. Improved vision Macintosh blade. Here again, there is an acute concavity on the blade. This increases your vision. So this is called an improved vision Macintosh blade. Coming to the Miller's blade or the straight blade, modified by Sir Robert Miller in 1941. He initially started off with adult blades. Later on in 1946, he made the pediatric versions. The characterizations, it is shallow at base. This is what he said he didn't like in the previous blades which were used by otolaryngologists. They were very thick here. So he made them shallow and he made them narrow at the tip. The tongue is straight and there is a slight upward curve near the tip. If you can appreciate this, the flange, the web and the tongue, here if you see the cross section is a C with the top flattened. It is positioned posterior to the epiglottis. So what does it do? It takes the epiglottis along with it. So we are basically lifting the epiglottis directly in a straight blade or in a Miller's blade. So it scoops up the epiglottis and traps it. These are the words the examiners want to hear very clearly in the oral exams to expose the glottis. The size ranges for 0 to 4. Right. So when Miller introduced the pediatric version in 1946, he made the blades, of course, slimmer than the adult version. And the curve was much more intense than the adult blades. These are the presently used Miller blades that we use, both the adult and the pediatric variety. So what do you think are the important differences? Again, another exam question that if you see this blade, the present day Miller blade, the curve is lesser. The height of the flange is reduced. Okay. So, and this is a compressed D-shaped curve. This is almost a C-shaped curve. Coming to the tongue, it is even more straighter than this. And if you see initially in the original Miller's blade, the endotracheal tube would be introduced through this channel which was formed between the tongue and the flange. Nowadays, we can introduce the endotracheal tube through the corner of the mouth, just like we do in a Macintosh blade. And we have the fiber optic varieties of the Miller blades now. So another exam question, advantage of Miller blades, and why do we think that the Miller blade has become an integral part of the pediatric airway management. What are the characteristics which helps to use the Miller blade in pediatric patients? One, that the tip of the blade is slightly curved. In the distal 2 inches of the blade is slightly curved, and this is very ideal for elevation of the long floppy epiglottis that is characteristic of infants and neonates especially, which tends to slip out of the smooth rounded tip of the Macintosh blade. So that's why we prefer Miller's blade in neonates and infants. Better vision with a straight blade when compared to curved blades, because the larynx is anterior placed. See, so for every physiological or anatomical change in a neonate, he had a solution, Robert Miller. So infant larynx as such is anterior. That's why this straight blades give a better vision. And the shallow base of the straight blade occupy less space, so it is easier to enter the fish mouth. You know, they have chubby cheeks and small mouth opening, so it's easier to introduce the blade than the curved blades, right? So this is a chart which shows which blade is preferable for children. If you see this up to 12 kgs, that is up to around 1.5 years of age, it is preferable to use the Miller blades. Thereafter, you can go ahead with the Macintosh blade. So here again, you can see the epiglottis is lifted directly with a straight blade, and the epiglottis is lifted indirectly with a curved blade. Coming to another very common blade which we use and which is an important part of the difficult airway cart, that is a standard McCoy blade. So which is based on the designing of a standard Macintosh blade. So when we introduce the blade, we introduce it just like any other Macintosh blade. But what happens, suppose we are not being able to lift the epiglottis, or the epiglottis is long enough, or we cannot manipulate the cervical spine. In these cases, we just activate this lever. If you activate a lever, it will be pushed. If you push the lever towards the handle, it gets activated. Once the lever is activated, the distal 2.5 centimeters of the blade flexes upwards 70 degrees, and therefore it elevates the epiglottis very easily without much pressure and force, and therefore it brings the larynx into view with a much lesser stress response and minimal cervical manipulation. Coming to two specific blade, laryngoscope blade, that is called the stull laryngoscope or the suction laryngoscope. If you see, there is a suction line which extends from the tip of the blade up to the handle, and there is a finger operated valve here, or knob here, which if you press, there'll be suctioning. So you can, this is of great help in patients with a lot of blood or a lot of secretions in the mouth. Coming to the oxyport blade, I'm sure many of you must have seen it. There is a channel for oxygen insufflation in this blade. And in both these categories of blades are available in both the Miller and Macintosh variety. So what are the uses of laryngoscope? Endotracheal intubation, yes, we all know that. Foreign body removal, upper airway lesion biopsy, visualization of the vocal cord and larynx, for insertion of a nasogastric tube, insertion of throat pack. At times we need to do a pharyngoscopy rather than a laryngoscopy to guide LMA insertion. And when you use the blade of a laryngoscope to insert the OPA, facing the patient, okay, facing the patient standing on the side, we just use the blade to push down the tongue and insert the OPA, which is in the non-rotation technique. So coming to a bit of positioning of laryngoscopy, because whenever you'll be handed a laryngoscope, you may be asked what is sniffing position and what are the other positions that you can provide to get a good laryngoscopic, base for a laryngoscopy. So what is a sniffing position? It is flexion of the lower cervical spine and extension of the head at the atlanto-occipital joint. So how do you do flexion of lower cervical spine? You keep a small pillow under the head, around 7 to 10 centimeters height. And how do you do extension of the head? By a slight pressure on the top of the head or the forehead, and or upward traction on the upper teeth or gums. These two maneuvers are enough to give you a good positioning for a laryngoscopy. The story is slightly different in infants and children. I will come to it in my next slide, but there are three things we need to keep in mind. One is to align the glabella horizontally with the chin in case of infants, and with the nose with the chin in case of toddlers. Open the anterior neck space and align the external auditory meatus with the suprasternal notch. Right. So in adults, whenever we give this sniffing position, we will get a good laryngoscopic view in a normal airway. Whenever this is for, especially to, I would request the postgraduate trainees who still are learning their laryngoscopy in the first year, try to identify the anatomical structures whenever you do a laryngoscopy. And if you can't, please ask your teacher, your guide, whoever is teaching you. It's very important to understand the structures, because you will be the first person to do the Cormack-Lehane grading once you can visualize and ascertain what structure you are seeing. Right? So what you'll see a vallecula, you'll see an epiglottis, the vocal cords, the tracheal opening, the arytenoids, this again is an important point when you do Cormack-Lehane grading, and piriform fossa and the esophagus, right? So as I was talking about infants, if you concentrate on this neonate, in neonates, just a shoulder roll is enough. And you may have to put a small donut under the occiput, because the occiput again is very prominent and the head becomes wobbly if you don't. But just a roll, shoulder roll with a towel is enough to give you this position. However, in an infant, if you see there is point 1, 2, and 3. Point 1, as I said, a straight line between the chin and the glabella. Point 2, you have to make sure that the anterior neck space is open. And point number 3, the external auditory meatus and the suprasternal notch should be in a straight line. So we put a shoulder roll, and we may have to put another towel folded, another small donut for the headrest. Toddlers, the story changes a bit slightly. Instead of the glabella, we take the nose and the chin plane, and the rest are the same as in an infant. One thing we have to keep in mind, that overextension of the neck must be avoided, because in this way the anterior larynx will go further anterior and make our laryngoscopy more and more difficult. So in the year 1984, R.S. Cormack and L. Lehane, these two gentlemen actually, they put their heads together to formulate a grading system, and which was based on the view of laryngoscopy. And this helped us immensely, not only for clinical studies, but also it helped the anesthesiologist who was supposed to handle a patient with a history of difficult airway, who has undergone a difficult airway, cancellation of the case due to difficult airway. What did the last anesthesiologist see? So this is how it helps us. So what was the initial grading? Grade 1 was full view of the glottis. Grade 2 was partial view of the glottis or arytenoids. Grade 3, that only epiglottis is visible. And grade 4, neither the glottis nor the epiglottis is visible. However, some of the anesthesiologists, as we started working with the grading, they realized that this Cormack-Lehane grading system was done with or without any laryngeal maneuvers or any laryngeal manipulation. And whatever the best view was visible, the grading was based on that. And they found in 1998 that it would be more specific if 2 was classified into 2A and 2B, where 2A was partial view of the glottis and 2B was just the arytenoids or the posterior chink of the vocal cords are visible. So if you see this, this is a very beautiful illustration where this is grade 1. Grade 2A, if you see the partial glottis, grade 2B, it's just the arytenoids. So it's important to know where the arytenoids are, and just the posterior part of the chink of the glottis. And grade 3 is just the epiglottis. Another gentleman called T.M. Cook, he published an article where he has actually clubbed the Cormack-Lehane grades into 3 easy, restricted, and difficult view of laryngoscopy. When prior to that, the 3 was again disintegrated into 3A and 3B. So now we have 1, 2A, 2B, 3A where epiglottis is seen and liftable, 3B is epiglottis is seen and not liftable, and grade 4 where nothing is visible, right? So what did T.M. Cook do? He clubbed grade 1 and 2A as a group of patients who will have easy intubation. So 95% of these patients would have a straightforward intubation. For 2B and 3A patients, there would be a restricted intubation and a restricted laryngoscopy. We may have to use a gum elastic bougie or other intubation aids to intubate these patients. However, in 3B and 4 grade of patients, 75% of these patients showing this view will have difficult intubation. And if you we face about 1.5 to 6% of unanticipated difficult intubations, in spite of them being absolutely anatomically normal when we have seen them in the PSC clinic. Right, so we need to at times look around the corner when a direct rigid laryngoscopy does not help us. And these are the other instruments or other optical aids which comes along with the laryngoscopes, which helps us to look around the corner. So there is a Prism type, which is a prototype of TrueView is one of the prototype of Prism type. Optical type, for example, the BULLARD laryngoscope. Optical stilet type, for example, the Bonfils retromolar laryngoscope and the video laryngoscope. So I will be dealing with only 3 of them. They are very complicated laryngoscopes, which I won't go into the major details, but at least we should know how does it look and what are these basic characteristic features. Right, so these are spotters. This is a TrueView. This is a BULLARD laryngoscope, the Bonfils retromolar intubation fiber scope, and the video laryngoscope. Right. Coming to the TrueView or the Prism type. Prism, actually, what does Prism do? It refracts light. Okay, so here it refracts light to bring the laryngeal view in the line of vision. The optical system view tube, it consists of prisms and lenses, and these lenses and this prism actually extends the view beyond the end of the blade. The refraction anterior refraction angle is around 35 degrees. There is a telescope which is angled at 42 degrees and it is molded along with the blade. And this provides a very good view for an anterior placed larynx without much manipulation. Coming to the BULLARD laryngoscope, there are 3 channels, of which 2 are fiber optic channels, that is a light and image bundle, and there is a working channel. There is an anatomically thin curved blade and an eyepiece. Now this eyepiece is the extension of the fiber optic viewing channel with a dioptric adjustment. Now you can either use the eyepiece directly to look into the laryngoscope, or you can attach a camera to a monitor and view it. And there is a handle which it can be attached. You can appreciate how the tube has been fixed on the BULLARD. Coming to the Bonfils retromolar intubating fiber scope, it was actually or primarily designed to intubate children with Pierre-Robin syndrome. Not very long ago, 1983, rigid straight fiber optic device with a 40-degree angulation of the tip. 40 centimeters long, 110 degrees angular view. So the wide angular view handle with an eyepiece is present. Again, the eyepiece can be connected to the monitor, and 3 sizes are available. 2 pediatric size of great help in pediatric patients, 3.5 millimeter external diameter and a 2 millimeter external diameter. So when used easily in neonates too. Complications of laryngoscopy, yes, damage to the teeth, gums and dental prosthesis, bruising and laceration of any anatomical structures in its path. Too much of cervical manipulation, especially patients with history of cervical spine trauma, will lead to an injury to the cervical cord. Swallowing or aspiration of a foreign body. There are dreadful literatures or case reports where the bulb has gone into the esophagus or to the or inside the bronchus. Burns due to malposition of the blade on handle can produce a short circuit which leads to rapid heating of the handle. Laryngoscope malfunction. Who has not faced? All of us have faced this, and when we need it to light it the best, it fails us. In spite of checking and rechecking with our intubation trolley time and time again. The laryngospasm and vagal stimulation, very important in pediatric patients because we go beyond the epiglottis and posterior to it, and if the patient is not in the adequate plane of anesthesia, you may land up with a bradycardia and a cardiac arrest. A hemodynamic response to laryngoscopy and intubations. I would request all of you all to please go through this article if you have not gone through it yet. Disinfection of laryngoscope, very interesting article published in Indian Journal of Anesthesia in 2017. The authors actually tried to find out the methods which were used by anesthesiologists, and they created a survey with a 13-point questionnaire in an anesthesia conference. And what was found that how many of us disinfect the laryngoscope handle and the laryngoscope blade. We all know that laryngoscopy is an invasive procedure. The blade touches the mucous membrane, it touches the saliva and at times the blood. The handle too, you know, we forget the handle, but when in the closed position, the tip of the blade most of the times touches the handle. So the handle needs as much as care and disinfection as the blade. So if you see the graph, the pie chart here, 46% has shown awareness to disinfect the handle after every use, whereas 11% says that I don't disinfect generally. And in this pie diagram where decontamination of laryngoscope blade has been spoken about, only 51% of us are just washing with detergent, so which is not sufficient at all. And the tragedy is 6% of us said that we don't know how the handles are decontaminated or disinfected. So what we gathered from the, what the authors concluded from this paper, from this study, is that the disinfection protocols are very varied, and so is the awareness. And we need a national guideline or national protocol actually formulated to disinfect and sterilize semi-critical and critical instruments that we use in a regular manner in our anesthesia practice. Right, so in present COVID era, and if you're using the laryngoscopes in patients with seropositive patients, it is, and if you are economically okay to go ahead, it's always better to use disposable blades. Otherwise, the blades needs to be cleaned with soap and water, followed by wiping with 70% alcohol or 0.1% chlorhexidine in 70% alcohol. Blades can also be autoclaved without the light carrier. Handles also needs to be wiped with 70% alcohol or chlorhexidine in 70% alcohol. And these are the guidelines which are published by the Healthcare Infection Control Practices Advisory Committee called the HICPAC. Right. So I wish to wind up by summarizing that in spite of innumerable laryngoscopes and that has been invented and designed, the design that stood the test of time is the Macintosh curved blade for most patients, and of course the Millers for a pediatric anesthesiologist. They have been a boon and will remain a boon for our lifetimes. Thank you so much for giving me a patient hearing. Please, we are open to comments and questions. Thank you.
It was an excellent lecture encompassing almost all facets of rigid laryngoscopes. And we will hold the questions from now. If you have any questions, please put it in the chat box. We will take up all the questions after the sessions are over. So now we will move to the next lecture, which is of course Fibreoptic or flexible laryngoscopes, which are an essential part of the anesthetic repertoire now. It has changed the management of difficult airway. When we were students, we used to have lots of trouble deciding against how to proceed in the case of anticipated difficulty airway. Now the guidelines are quite straightforward. Most of the institutions have some sort of a flexible scope in their position and they're regularly using it. I am sure most of the postgraduate students are also using it on a regular basis, at least in most centers. So this is an essential equipment that you need to master. And this is also has become an essential equipment. It's going to become an essential equipment on the examination board as well, examination table as well. So over to you, Dr. Shah. And I think the next 1 hour is going to be extremely interesting.
Thank you, Dr. Palash. At the outset, let me thank ISA West Bengal for organizing such an interesting sessions and also giving me opportunity to speak to all of you. And I must say, Dr. Kastu, it was an excellent presentation, taking me back to the, I would say,
thank you,
my
thank you, sir.
So we will now move to the my presentation, that is Fibreoptic bronchoscope, Fibreoptic intubation, I would say. So this is, fortunately, I got an hour or so. So I have divided my Fibreoptic intubation lecture in, I would say, okay, can I go ahead? Yeah. I have divided into 3 segments. One is applied anatomy of endoscopy. That means you should know what you can look into the endoscopy. Then the anatomy of endoscopes. That means some basic knowledge about endoscopes. And then the 3rd segment, tips and tricks for successful flexible endoscopic intubation. So applied endoscopic anatomy is very, very important. It is important for identification of structure. You know, in the anatomy, what are the structures, but when you look at it directly from the endoscopy, they appear slightly different. And also the vision changes the way you look at it. So vision orientation becomes very, very important from where you stand, from where you are doing your endoscopy. What is your orientation of the camera? And of course, you can always assess distance, angles, and directions. Suppose if you are doing a nasal, first let us look at the nasal cavity endoscopy. The landmarks are, important landmarks for us are inferior turbinate, the middle turbinate where we are not supposed to go, floor of the nose, also soft palate, posterior nasal wall, and eustachian tube opening. So all these structures we should be visualizing, we should be trying to go through it. Is my slide seen? Is it visible?
Yes, visible.
Visible, okay.
Yes, sir, it is.
Yes,
Okay.
sir.
Great. So I'll go ahead. So these are the important landmarks in the nasal cavity. If you see the cut section of a nasal cavity, this is a classical cut section photograph which you must have seen, but this is when you look at it from the front. The way ENT surgeon look at the nose, when you look at from the front, this is what you are going to see, inferior turbinate hanging from the top. But when you are in a conventional laryngoscopy position and when you do Fibreoptic bronchoscopy, or when you attempt Fibreoptic intubation, the vision is, if you are in a conventional position, it is exactly opposite. So if you look at it, if you are looking at from the front, the nasal floor is actually a floor of your vision. Turbinate hangs from the top and the septum is on the right. But if you look at from the conventional laryngoscopy or a Fibreoptic intubation position, things are different. Your nasal floor become roof of your vision. The inferior turbinates, like they are elevating themselves from the base. So it looks different when you are, the way you perform your endoscopy. Oropharynx endoscopy, again, when you are performing from your conventional position, larynx looks, in a conventional picture, the way we have seen it. But if you are doing it from the front, the laryngoscopy, Fibreoptic intubation or Fibreoptic bronchoscopy from the front, larynx actually looks opposite. So our ENT colleagues are used to this position where the larynx looks, to the opposite than what we have seen in the picture. or what we have seen in laryngoscopy. So you must remember that and you must understand that. The hypopharyngeal part, again, the some part of anatomy was covered by Dr. Kasturi. When you look at the larynx, the top part above epiglottis is called vallecula. There is a pyriform fossa on the side and the area epiglottic fold which starts from the side. When you look at closely, this is stroboscopy picture where you can see that entire structure of a larynx from the area epiglottic fold to the false vocal cord. It is called vestibule. You must identify false vocal cord, and then there is a white structure which is called true vocal cords. When we have a cyst or a swelling of a false vocal cord, true vocal cords are not seen, and it is very important that you differentiate between false vocal cord and true vocal cords. Pyriform fossa is internal branch of supralaryngeal nerve, and you can actually put platelets of local anesthetic solution there, and it can give you an anesthesia of superior laryngeal nerve. Trachea and subglottic anatomy, we know about it that the trachea starts at the inferior border of a cricoid cartilage at C6 cartilage, and it vertebra, and it ends at into thorax at T5 vertebra. It has some 18 to 22 cartilaginous rings which are deficient posteriorly. The course of trachea follows the spine. It deviates slightly to the right at the bifurcation. Length is around 9 to 15 centimeter and outer diameter, 21 to 27 millimeter outer diameter and internal diameter of 12 to 18 millimeter. There are 2.1 ring per centimeter. So nearly 2 rings are there in a centimeter, and this is important when you want to position an endotracheal tube. The trachea becomes intrathoracic at 6th ring. So by 3 centimeter or 3 to 4 centimeter, it becomes intrathoracic. When you look at the endoscopic anatomy, this is a normal trachea which is wonderfully visible here. What you can look for is something, we call it the cathedral sign. Cathedral sign is basically incomplete cartilage which are deficient posteriorly. Posteriorly, you see a well-defined longitudinal muscle along the posterior portion. When you look at the carina again, we'll see a bifurcation into right and left main bronchus. Again, there are on both the sides there are deficient cartilages and racing stripes on the posterior surface. Now, this orientation is very, very important when you are trying to look at when you are trying to identify double lumen tube position or when you are trying to place a bronchial blocker. Because if your camera is opposite, then you might have a picture like this. And if you're not able to understand, and if you're just focusing on two lumens, then you might give the left side may be right side and right side may be left side. So it becomes opposite and your planning becomes difficult. So it is very, very important to orient yourself, and you should know what looks normal. The innervation of the airway, I'm not going in much detail for the anesthesia part. The nasal part is supplied by the trigeminal nerve, ophthalmic division and maxillary division. Am I audible and my slides are seen? See, I'm trying to repeat because I don't see my picture and my view. Okay, fine. So trigeminal nerve supplies the nasal part. There are through its two division, ophthalmic division and maxillary division. The oropharynx is supplied, or the sensory innervation passes through glossopharyngeal nerve, and lower down it is all vagus nerve. Superior laryngeal nerve above vocal cord, and everything below vocal cord is recurrent laryngeal nerve. Now there are various techniques of giving anesthesia to that. There can be individual nerve blocks which glossopharyngeal, superior laryngeal, transcricoid injection, pterygopalatine ganglion can also be blocked, or a generalized topical technique which is more favorable nowadays. Spray as you go, that means you spray anesthetics as you are going in. You can do nebulization or atomization, which also covers majority of the area. You can use local anesthetic gels, spray, gargles or lollipop for a different area. More important thing here is that more than one technique is needed to accomplish a complete airway anesthesia. In which combination, it depends upon your comfort level, your expertise and availability of your equipments. What we use at our center, we use either platelets or gel, lignocaine gel for lubrication as well as anesthesia. And sometimes we use atomizer. Atomizer is, we have a customized atomizer which we use it for our own purpose. So atomizer for nasal anesthesia, atomizer can be used for the oral anesthesia also, or a glossopharyngeal nerve block. So, also surface applications like spray, gel or gargle can also be used for the oropharyngeal area. Superior laryngeal nerve works very well for the area above vocal cord, but atomizer also works there equally. So atomizer, if you have an atomizer which works in the sense the customized atomizer which we are using, it works for nasal, oral as well as right up to the superior laryngeal block. Below vocal cord, what we need to do is give transcricoid injection or use spray as you go technique when we are performing the fiber optic intubation or fiber optic bronchoscopy. Again, emphasizing on this point, you need to use more than one technique to complete the airway anesthesia, because this is quite long and curved, and one technique will not work for entire airway. So that was all about the anatomy of endoscopy. Now we would try to learn and understand some fiber optic bronchoscope or video bronchoscopes itself. So what is an endoscope? Endoscopy is view within, that is endomscoping. This is a Latin word. So it is essentially looking inside, and endoscope is used to examine interior of a cavity or an organ of a body. The various types of endoscopes are used by us. We flexible laryngoscope, flexible bronchoscope, and we also have video bronchoscope. Flexible laryngoscope is more often used by ENT doctors, ENT surgeons. It has the length of only 35 centimeter. So you can visualize up to larynx, but you cannot go beyond that, and putting an endotracheal tube through it is very difficult. So what we use is a flexible bronchoscope, which is a longer length. Now, I always used to wonder how a bending or a curved pipe allows visualization as well as image transmission of light and image. So this is through an optical fiber. What is an optical fiber? Optical fiber is a heated stretched glass. Diameter is approximately 8 micron, which acts as a waveguide or a light pipe. So if you know basics of optical fibers, they are made up of glass or plastic. It actually has 3 layers. Central layer is called the core. Outer side is called cladding, and outer to that is a buffer, which is a coating. So both core and claddings are made up of glass or plastic. Only thing is their refractive index is different. So refractive index of core is different than the cladding. So when a light is transmitted, rather than passing through it, it is internally reflected. So it is internally reflected so that light and image both can be passed from one end to the other end. So when you throw a light into one of such fibers or such pipes, you will see light at the other end rather than spreading through the tube. So there is total internal reflection and light transmission. This happens for the image as well as light both. Now in our fiber optic bronchoscopes, there are bundles of such fibers, 2 bundles for the light and 1 bundle for the image, and there are around 30,000 to 60,000 fibers in each bundle. So there are 2 types of bundle in our fiber optic bronchoscope. It is light fiber and the image fiber. Light carries light from source into the body cavity, while the image fibers carries image of cavity back to the physician for the viewing. If you see position of various fibers inside, the image carrying fibers are coherent bundles, while light carrying fibers are incoherent bundles. Now, what do we mean by coherent and incoherent bundles? Incoherent bundle means their end positions are not uniform. They can end at any place. But if same thing happens for the image fiber, imagine the image of a nose or eye carried by some fiber optic bundles, which is positioned at somewhere else, so it will be totally distorted. So what we need is a coherent bundle for the image fibers and incoherent bundle for the light fibers. Light may can reach to the any fibers at any end, and still we'll have a clear light or a equal light. But if that happens to the image, then you will have a distorted image to the eyepiece lens or imaging lens. If there is damage to the illumination fiber or light fiber sucker, you will have a clear picture, but the image, the light intensity will be very less. But if there are light image fibers are actually broken, or if there is damage to the image fibers, you will see black spots. So if there is black spot, that means on your fiber optic image, that means your image transmitting fibers are damaged. You also see when you attach a camera, and if you try to do fine focus, you see fine mesh-like appearance with the fiber optic bronchoscope. This is especially with fiber optic bronchoscope only. The reason behind that is there is a coating or a packing around image fibers, and this image, the area where there is no image transmission, creates a mesh-like, fine mesh-like appearance. This happens when you do a fine focusing. If you defocus it slightly, you will see a clear picture. Now, this is a fiber optic endoscope or fiber optic bronchoscope. Nowadays, with the technology innovation and advancement, we are also getting something called a video bronchoscope. So in video bronchoscope, instead of image transmitting fibers, instead of optical fibers, there are camera which is used. So camera is placed at the tip of a fiber optic video bronchoscope for the image transmission. For the light transmission, it is not necessary to have LED lights. It is either LED light or it could be optical fibers. Now, how do we differentiate between video bronchoscope and a fiber optic bronchoscope? One important difference would be there is no eyepiece. In case of fiber optic bronchoscope, you need an eyepiece to view directly, or over that you can connect camera. Here, in case of video bronchoscopes, there is no eyepiece because image is processed in a processor. So image is directly processed, and that processed image is seen on the screen. So there is no eyepiece, but there will be processor. For the light transmission, as I said, optical fibers or LED bulbs can also be there at the tip of a video bronchoscope, which will transmit the light. So video bronchoscope is less fragile because there is no optical fibers, which are actually quite delicate and fragile. The image quality could be better, but it is a process image, and of course it is costlier. Well, in case of optical fibers, you may see a mesh-like of appearance when you try to do fine focus, and the optical fibers are quite delicate and fragile, and you really need to handle them carefully. So fiber optic technology, the view is a natural color or a normal color, but the focus and the image quality is slightly inferior, versus in a video bronchoscopy technology, the image is much sharper, but they are processed image and can be slightly of a different color. Now, when you think about a fiber optic bronchoscope, there are 4 major systems in any fiber optic bronchoscope. It is a mechanical system. There would be a plumbing or instrumentation system. There is illumination system and image relation system. The fiber optic bronchoscope, the major or the main part is called the control body. This is the control body where everything can be controlled from there. There is a lever for tip movement. The eyepiece is connected to it. The optical fibers are connected to it. The image lens is here, which transmit image to the eyepiece, and also light fiber or a light guide is also connected here. So this is called control body. The part which goes inside patient's airway is called insertion tube. Insertion tube has 2 light bundles, 1 image bundle, and also if it is of enough size, and then there will be instrument or a suction channel. The distal tip, 5 centimeter, has actually a spring-like structure, which helps us in bending the tip. So tip can be bent with the help of a lever which is there in the control body, and this tip bending will help us into going to the various area, and which we'll see why it is important. So tip bending, That is called bending section, which is last 4 to 5 centimeter of a fiber optic. The tip of fiber optic bronchoscope has 2 light transmitting bundle, 1 image transmitting bundle, and 1 channel for the instrument or a suction. Majority of the fiber optic bronchoscope has a light guide or a cord which can be connected to external light source. Nowadays, separate light source where battery operated light source is available, which can be directly connected and which you can help us in visualizing the structures. So either a battery operated light source or a light cord is available which can be connected to the external light source. The bronchoscopes routinely are available in 55 to 60 centimeter length. They are of various diameter from adult to pediatric one. What important thing which we have to understand is how much area which is seen, which is called field of view, and how much distance you can visualize. So field of view is essentially what we call it the perimetry, how much area is visualized, and depth is how much distance you can see. Now, as your light transmission goes down, your field of view and depth of field both will go down. Also, if you have a pediatric bronchoscope, his depth of field is less, field of view is also less. So you see lesser amount of structure and also at lesser distance. So you really need to go near to the tissue to visualize that particular tissue. So you must understand what sort of bronchoscope you have, what is depth of field and field of view to locate and understand and identify various structures. To handle a bronchoscope all the way, this is one thing which is very, very important. You always have to keep bronchoscope insertion cord straight and taut. It has to be straight. It has to be taut. If you flip it, if you keep it at curve, the movements are not transmitted to the end. You can use dominant hand or non-dominant hand, depends upon your understanding to handle the body and the tip guidance. One hand is used to hold the control body, and the other end is used for the tip guidance. There is no clear-cut guideline or the information which tells us that this can be used or this is more advantageous. It depends upon user's personal preference. There are 3 sets of movement which is possible with the fiber optic bronchoscope. One is up and down movement of the tip, which you do with the lever which is there in the control body. Also a side to side movement of the scope which will help us in rotation, especially when tip is actually angled. You can see from the view is almost 180 to 360 degree with the help of side to side movement. And of course, one is a straight line or a forward movement which you go in as you proceed. Operation room setup is also very, very important. If you have not placed it in a proper position, the equipment like monitor, your light source, your instrument trolley, your suction machine connection, and your assistant position. These are very, very important consideration when you are for a successful fiber optic intubation or a fiber optic bronchoscopy. So if you are doing it from your conventional position of laryngoscopy, when you are standing behind head of the patient, the monitor is always in front, and the lights, your suction and light source both comes from the left side. So it should be on the left of your position. But if you are doing it from the front, the way the way ENT surgeon does, the way many European country consultant prefers to intubate the patient from the front, that means then a position of monitor and everything will change. So if you are doing it from the front, then the suction and monitor is always in your front and suction is always on your left side. But if you are doing it from the back of the patient or from the head end, then the position of monitor is in your front towards right of the patient. You always have to use platform to adjust the height so that your insertion cord remains straight and taut. So this was all about anatomy of endoscope and endoscopy. Once we have understood the equipment, once you have understood the anatomy, we are ready to perform fiber optic intubation. And in next section, what we'll discuss is what are the problems, tricks, troubles and techniques of performing successful fiber optic intubation. So this was one of the fiber optic intubation performed live in one of our conferences. And when it is used by an expert, the intubation looks pretty smooth. Things go right into the, there is no hiccups at all. You go right into the trachea, you guide the tube without any difficulty, and patient is quite comfortable. So when it is done by an expert, and if it is done correctly, things looks pretty easy. But there are difficulties when you start performing it for the first time, or when you are in your early part of your course. So we'll try to identify troubles and discuss the solutions to this trouble. Now, the first trouble, which is very common, is uncooperative and anxious patient. If patient has not understood the importance of the fiber optic intubation, need for fiber optic intubation, then it is very, very important that you explain them well for the need of awake fiber optic intubation, or else you may have to give some sort of sedation or anesthesia. And also airway anesthesia is very, very important for a successful fiber optic intubation. We already discussed some part of airway anesthesia. Sedation, I am not going in detail. It varies from center to center, institute to institute, but routinely, if you are not doing it in complete anesthesia, then dexmedetomidine, ketamine, dexmedetomidine, fentanyl, and ketamine are the drugs which are used regularly, and you have to give airway anesthesia well. The fiber optic endoscopy and intubation can be divided into, I would say, 4 steps to understand them. We can decode them into 4 steps. The first step is nasal or oral passage to the larynx. The second step would be your further passage from larynx to subglottic area. Step 3 can be, further following curve to the carina. And step 4 would be passage or railroading of the endotracheal tube. If you divide them into these 4 steps, then we can easily identify problems or troubles with each step. So let us look at the problems or troubles of step 1, that is from nasal cavity or oral cavity to the laryngeal opening. Now, majority time there is a difficulty in nasal passage, which can be quite narrow sometimes. You may have difficulty in identifying the anatomical landmarks. You can be lost in oral cavity, you can be lost in nasal cavity, and you are not able to identify the glottic structure. So the solutions are like, there are multiple solutions of each different problems. We'll go them in slightly more detail. First, you must test the patency of nostril and identify which is more patent nostril for your fiber optic endoscopy, nasal endoscopy. So whenever you are doing a nasotracheal intubation, you must identify which nostril is more patent. There are various ways you can ask patient to occlude one and see the expiration through each and identify which one is easier. You can also use fogging on your metal blade and identify which side is better fogged. Or you can use 30-cum speculum to look inside and identify which side is more broader and which side is narrower. So you must test patency, and whichever side is more patent should be used for fiber optic naso and nasotracheal intubation. When you are entering into nasal cavity, you must remain inferior to inferior turbinate. Between inferior turbinate and floor of the nose is the widest passage, most straight passage, straight down to the line. So that is the area you must remain in, that particular passage only. So you must remain inferior to inferior turbinate, or if you are doing it from the front, you are superior to inferior turbinate, because nasal floor is your roof. So between floor of the nose and inferior turbinate is the area where you should go. It is a straight passage right down to the nasopharynx. If the passage is really narrow, you can use serial nasopharyngeal airway to dilate the nasal passage and then use appropriate size fiber optic bronchoscope. If not giving you adequate area, you can use smaller size of scope, or in case if there is a real nasal obstruction, you can change over to the oral route. The next is you lost everywhere and anywhere. It is because of lack of application of anatomical knowledge. It could be because your vision is not seen because of secretions or bleeding or any other technical issues. So when you are not able to identify anatomical structure, it is very, very important to go slowly. Identify each and every structure. Always identify inferior turbinate and the floor of the nose. Try to visualize for restriction tube, posterior pharyngeal, posterior nasal wall, which is two straight line which is seen, or the movement of the soft palate. When you identify this structure, your progress becomes very easy. So it is important that you identify all the structure. Second important method is just follow the black. Now, if you see here, now you can appreciate three colors here. One is pink, second is white. Pink is a tissue color. White is a color of the light reflection, and the black is air passage. And what we call dictum is called the follow the black. So you always go in the direction where there is a black passage, because black denotes, tells you that these are the air passage, and you go towards black. So follow the black is a dictum. Wherever there is a black area, you try to follow that area and you will go towards the airway, because that is a black area, it denotes that it is a air passage. Wherever there is a black, you go towards black. You can predict the at which you should be able to visualize the vocal cord or larynx from the distance. So length prediction can be done same way as we do it for the nasal or oral airway. You identify the length, and when you insert that much length, you should be able to see the larynx. If you are not able to see larynx at that much distance, then probably you are somewhere else, or your technique is not correct and you have to revise that. There are many times secretions and bleeding comes in your way. There are various methods. If you have non-channel fibroscope, which is not so advisable situation, or it should not be used ideally. If you have that and you don't have any other choice, you can do suctioning through opposite nares. You can do suctioning through oral cavity and try to clear everything. But if you have channel fibroscope, you can do suctioning through channel, so which will reduce do secretion suctioning, or you can remove some amount of blood which is there through instrument channel. In awake patient, if there is a lot of secretions, you can ask patient to swallow the secretions. Ask patient to swallow the secretion. He will swallow and your secretions will go down. If you are lost, if you are trying to do oral intubation, then it is very easy, because oral cavity is quite large while nasal cavity is a smaller passage. So you go in straight one line only. While in oral cavity, you might be lost and you may not remain in center. So to centralize, you should always use airways. There are specialized airway which are available for a fiber optic intubation and fiber optic bronchoscopy. There are Oversapien airway, Burman airway, or we use a modified technique where we use a airway tube of our eye gel. You know, we cut open the silicone part, gel part, and then the stiff airway tube remains, which is of course our own version. It is a modified version which we are using if we don't have Oversapien or a Burman airway available. So that was step one, where you have reached larynx. Once you have reached successfully to the, then you have to go beyond vocal cord into the subglottic area. So troubles of this area is here, you are not able to enter into the vocal cord. Sedation will have epiglottis touching to the floor. Patient have coughing, laryngospasm or movement of the vocal cord denying you entry into it. And of course, fogging also occur quite frequently at this stage. And these are the various solutions. So first and foremost, the most important thing is that larynx is situated quite anteriorly. When you are going through nasal cavity or oral cavity, you usually touch the floor of the pharynx, and then larynx is quite situated up. If you see here, this is image intensifier view of a fiber optic fiber optic intubation. The larynx is situated up, so you have to go up. Your lever should go down, so tip goes up. And as you enter larynx, it is actually directed downwards. Trachea is directed downwards, so you have to immediately go down. So your tip should go up, and as soon as you enter vocal cord, your tip should be again going down. It should be directed downwards. If you are not able to do this maneuver, probably you will not be able to enter and go beyond that. Fogging occurs quite frequently during fiber optic bronchoscopy and intubation, but most commonly at this stage, as you are right in front of a breath. So there are various methods by which you can reduce fogging. You can contact the tip with any tissue. Just deflect the tip, and the tip will touch one of the tissue, and the fogging will go down. Insufflation of oxygen through instrument channel will also reduce your fogging, or you can remove the scope, immerse it in a warm water, and then proceed again, which will reduce the fogging. If you have given sedation, it is quite that you will see picture like this. Epiglottis right down to touching the posterior pharyngeal wall, and you have difficulty in entering into it. There are various methods which are available. You can ask someone to, if you're given sedation and anesthesia, you can ask someone else to elevate the mandible and give jaw thrust, which will elevate the epiglottis. You can take tongue out, protrude the tongue. If ask patient to protrude the tongue, that is one of the best solution if your patient is awake. If patient is not awake, then you can use a suction tip, suction tip, or an instrument or a stitch to lift and elevate the tongue. You can also do 2% techniques. That means one person puts a laryngoscope inside or a sort of soft laryngoscopy to take tongue away, and then the other person introduces the fiber optic bronchoscopy. So this is to avoid airway collapse. Making entry into vocal cord is another difficulty because of its narrow passage and a constant movement. So you need to give proper superior laryngeal nerve block, which will keep vocal cords wide apart. If that is not possible, then again you should give some anesthesia with the technique which is called spray as you go. You go in front of a vocal cord, spray over vocal cord, which will anesthetize that, will prevent coughing. You need to really keep patients at this particular stage as it really requires an experience and trick to go in. This is, I would say, most difficult part to enter into the larynx. Is most difficult part of all. You should try to slide through the wider posterior opening. So that is the area you should try, and from there you can easily go in. We have tendency, the moment you enter inside and you see the trachea, we feel that the procedure is over and we start sliding the tube. This should never be done. Do not slide endotracheal tube as soon as you enter vocal cord. So at the step 2, you should not enter and push the tube. Otherwise, slip out of vocal cord and you will have esophageal intubation. You don't know where you have gone actually. So advance scope right down to the carina, visualize carina, then only slide your tube. So that is a third step. Step 3, you follow curve to the carina. Now the problems of once you reach inside the trachea is you are not able to visualize the entire tracheal lumen and you don't know where you are. There is excessive coughing, esophageal bulging will not give you proper view. So first is, since trachea is not a straight pipe, it is directed downwards and towards right. So you have to maneuver your tip as well as you have to rotate the scope so that it goes to the, it gives you a central view. Patients coughing or swallowing will give you such a picture where you are not able to see that entire lumen. And if you try to force, you can cause injury to the trachea. So most important thing is wait, give proper anesthesia if your anesthesia is incomplete, if patient is coughing. And if patient is really swallowing, ask patient to stop swallowing so that esophageal movement stops and you have a clear entire picture of a tracheal lumen. Once you have seen the tracheal lumen, it's time to pass the tube. That is the step, we can call it step 4, that is railroading of the endotracheal tube or a passage of endotracheal tube. Now the problems at this step are the impingement or a resistance. There could be trauma and you have to properly put tube in a final proper position so that you don't do accidental extubation or a endobronchial intubation. So the impingement or a resistance occurs because the anatomical curve is different, that entire passage of tube, and also there are narrow structures on the way. So impingement can be of nasal or a laryngeal. Nasal impingement because of a DNS, deviated nasal septum, or a narrow passage. So when you have a resistance within first 10 centimeter of insertion of tube, it is because of nasal passage. And what you should do, you apply lubrication, use smaller size of endotracheal tube, or you can rotate the tube, sort of over a scope, and gradually push gently endotracheal tube. Do not use force. When you have a resistance, or when you are not able to pass tube once you insert it to 13 to 70 centimeter, you are likely to have difficulty or impingement at a laryngeal level. Here, laryngeal impingement most commonly occur at right area epiglottic fold, because when you use standard PVC tube, tip is on the right and bevel is facing towards left. So tip is likely to hit right area epiglottic fold, but impingement can occur all around. And one important thing which you can always do if you are facing impingement is to do counterclockwise rotation 90 degree. When you do counterclockwise rotation, tip goes up and the bevel is facing posteriorly wider, it passes through a wider area. And when you do counterclockwise rotation, tip comes in contact with the fiber optic bronchoscope. So you do counterclockwise rotation and you can easily pass tube most of the time. If you see various literature available, literature on fiber optic intubation, this was one interesting publication which says that awake fiber optic intubation after sedation resulted in higher acute laryngeal injury than conventional intubation by a direct laryngoscopy. But one other publication in 2007 said fiber optic intubation, awake fiber optic intubation is safe regarding vocal cord sequelae. Routine use is justified for anesthesiologists experiencing this technique. So, there are two opposite statements coming out from these two publications. And why is that? What is the difference between these two publications, intubation technique, that led to different type of conclusion? The reason was laryngeal morbidity and injury was less in second because they have used different type of endotracheal tube and they have used different size of endotracheal tube, so the gap was less. So we'll see in slightly more detail. There are 4 types of endotracheal tube which we are using for fiber optic intubation: a standard PVC tube, a standard tip but flexometallic tube. There are Parker flexi tip type of a tube now available, and silicone rubber tube of a fast track or intubating element tube. When you use PVC tube, the chances of difficulty are quite high. It is on the higher side. Impingement occurs because of stiff tube, the sharp tip which is on the right side, and the Murphy's eye. So the bevel is facing left and tip which is sharp is on the right. Also, difference between diameter of tube and the fiber optic bronchoscope we'll see in couple of slides is also very, very important. But when you use similar tip but flexometallic tube, it follows the curve of bronchoscope. So it is no longer stiff. It follows the curve of bronchoscope very easily. So the chances of success and chances of trauma is less when you compare flexometallic tube versus PVC tube. But if you have a provision of having a Parker flexi tip type of tube, which has a tip pointing towards center of a distal lumen. So during fiber optic intubation, it has a greater incidence of initial success compared to a standard tip, either PVC or a flexometallic tube. But a standard tip, when you compare it with the Parker flexi tip tube, it has a better incidence of success. The best tube would be a soft tip tube of a soft tip flexometallic tube of a fast track or an intubating element tube. This is soft. The bevel is slightly different. It is facing towards sort of a front and the tip goes into the center. So it remains in contact with fiber optic bronchoscope all the time when you compare with all other types of a tube. So silicone rubber tip, which is available with a fast track tube, it allows easier passage. It has minimum impingement at a nasal cavity and larynx. It is flexible, so it confers the shape of a bronchoscope, so it can be easily pushed in. And it is better and more successful compared to all other tubes. So the first choice for fiber optic intubation, if I have a choice available, then it would be silicone rubber tip of a fast track tube. Also important consideration is a internal diameter of tube versus the outer diameter of a fiber optic bronchoscope. If there is excess distance between inside of the tube and the insertion cord, it may lead to lot of snagging at laryngeal inlet. The chances of laryngeal inlet impingement is very high if the distance or the difference is more than 1.5 millimeter. If it is less than 1.5 millimeter, then chances of impingement is minimum if the difference between outer diameter of scope versus internal diameter of tube is less than 1.5 millimeter. So you should always choose the size 1.5 times 1.5 number higher than the fiber optic bronchoscope. So if your bronchoscope is 4, the ideal tube is 5.5. But if you have to use, say you have a pediatric bronchoscope, and if you have to use for an adult patient where you want to pass 7 size endotracheal tube, then you can use entry catheter. Entry catheter is specially designed to shield the tube and also to increase the diameter of scope so that the difference is minimum. The internal diameter of an entry is 4.7 millimeter, so you can very well use 4 size or lesser size of fiber optic bronchoscope. You can shield this with the entry catheter, which the length is 55 centimeter. So it is 5 centimeter distal tip is available for the maneuvering, and outer diameter is 6.5. So you can very well use it for an adult patient. So if you have to use pediatric bronchoscope for an adult patient, preferably use entry catheter, slide entry over the fiber optic bronchoscope, and then use endotracheal tube to improve the success. So tips for maneuvering, which I already said, 90-degree counterclockwise rotation of tube at the larynx. In fact, if you get the impingement at the laryngeal opening, withdraw by 2 to 4 centimeter before doing rotation. Otherwise, near rotation, very near to that, will continue to have impingement. There is also an interesting position of bevel, which we call it undo technique. So bevel should be facing up if you are doing nasal intubation, and bevel should be down in oral intubation to have a easy and successful intubation. We call it undo technique. When you have finally pushed tube beyond vocal cord, where should your tip of fiber optic endotracheal tube should lie? So that again you can do because we want to put tip at least 1 inch or 2.5 centimeter away from the carina, which will prevent endobronchial intubation if you do a neck flexion. So it should be at least 5 ring away from the carina. So you see the carina and place the tip of your endotracheal tube at least 5 ring away from the carina. Okay, so it is important that while you are performing the fiber optic intubation, someone should be watching the oxygenation, and you should try to use as many as technique to avoid hypoxia. So you should continue to give oxygen. You can give oxygen through instrument channel. You can also separately give nasal oxygen. You can in fact use high flow nasal oxygen, which has been used successfully, and it has been found that it reduces chances of hypoxia. You can give oxygen through oral cavity. You can use endoscopy mask, where you can give high amount of oxygen, and endoscopy is done through the port available on an endoscopic mask. You can use oxygenation through oral airway, and you can also use high flow jet ventilation through instrument channel. So use whatever means available to you to avoid hypoxia. Continue to give oxygen. Never forget about oxygen, though when you are actually trying to perform fiber optic intubation. Now, at the last segment of my lecture, we'll try to 3-4 slides of what are the troublesome equipment, few which we have already seen. If your light fibers are damaged, your image intensity, light intensity will go down, and you need to replace the fibers. If your light intensity is on the lower side, you may have to go very near to the tissue to identify that structure, and it becomes very difficult. If your image carrying fibers are broken, you will have black spots. So few black spots are not a problem, but if they are in large numbers and if you are really hindering your vision, you should replace the light fibers. If there is a lens in the distal tip of a fiber optic bronchoscope, if there is a secretion which comes in front of that, then you will have such hazy vision. If this is there, you should not continue with that scope and you should change and you should send that scope for the repair. Malfunctioning of the lever occurs once you use it for a long period, and always check that there is a complete tip movement is occurring before you proceed for the fiber optic intubation or fiber optic bronchoscopy, because without tip movement it is almost impossible or it is very difficult to perform fiber optic bronchoscopy and fiber optic intubation. So always check for the tip movement with the help of lever, and without checking, do not proceed for fiber optic bronchoscopy. If you are using fiber optic bronchoscope with a camera connection, and if you are trying to view on the screen, then it becomes very, very important that you orient it correctly. So for the proper orientation, there is a black mark available at 12 o'clock. So this black mark should always be kept at 12 o'clock. If you don't keep it properly, then you might have orientation problem and the vision might be looking like this, which we already discussed, that the right and left would be opposite to what is perceived or what is seen. So it is very important that you keep black mark on camera at 12 o'clock position so that your orientation remains complete and normal. So this is not acceptable. So that takes me to the end of my lecture. The art of endoscopy basic is that your best chance is your first chance. So be patient. Be patient. Try to arrange everything, organize everything so that see to it that everything is ready. Then only you proceed. Oxygenate through all possible route to avoid hypoxia during the fiber optic intubation procedure. Keep endoscope straight and taut so that your whatever you are doing with the wrist is transferred to the tip. Otherwise, your movement will not be transferred to the tip, and you will, in spite of you will try to move, and there won't be any movement to the tip of the tip. In fact, endoscopes want to be endoscopy, so it is you who is not intubating or not intubating. So it is your failure rather than endoscope's failure. You always remain in midline, get off away from the wall. Slow down, think and act if you are not knowing what is happening. If you don't know where you are, you probably should not be there. So if you lost, you don't know where you are, come back to a position where you can see everything, where you identify the structure, and then proceed slowly. Force is wrong. You should never give any force. If force is needed, you are doing something wrong, and you should come back to a position from where no force is needed. Slow down to finish faster. You treasure the basic value of any procedure: peace, harmony, and kindness to the patient. Consider you and endoscope are one. They are ready to do endoscopy. It is you who is doing or not doing. So do it with ease, slow it down, and then you can finish it faster. Thank you.
Thank you, Dr. Amit. That was a very exhaustive discussion, not only on the covering the theoretical aspects, the structure of the scope, and how to use it, the details of the anatomy, and most of the problems that you will face in your day-to-day practice, because it's not only the technique, it's an art as well to use this thing. So there are a couple of questions. Dr. Shaikat Sengupta wants to ask about the pediatric fibroscope, the entry catheter technique that you showed. He wants to know that with an entry catheter, will the length be a matter of concern?
Yeah, see, in fact, most of our bronchoscopes are 60 centimeter, and entry catheter is purposefully made for this. So it is 55 centimeter. So last 5 centimeter, which is a bending section, is actually without scope, without entry catheter. So you can easily make the movement. So it will not be a problem. In fact, pediatric fibroscope, if it is of smaller length, then yes, entry catheter will be a difficulty. But majority of the scopes are of 60 centimeter. So last 5 centimeter area is left without entry catheter, which you can use it to maneuver the tip.
Okay, and if the scope size is too small, is it going to slide within the intracatheter and can
Yeah, then your tip movement will be
go down?
difficult. Yeah, tip movement will be difficult, and you will have more difficulty in maneuvering the scope.
Right. And and there is one question on the expected lines. I think we have still some time that we can spare. So I think a little bit discussion about the nerve blocks and the local anesthetic techniques, and maybe something what is you for find to
Okay.
be more.
Okay. Since we have a
In your
time,
practice.
what I'll do is I'll show you video.
Yeah, I think that would be nice.
Okay. So just bear with me. I'm opening my
Sure.
presentation. Okay. So it is there. I'll close this so that it does not come in my. Okay. So I'll share my screen.
Sure.
Okay. So airway anesthesia. So we usually need when we do fiber optic intubation. So this is actually airway anesthesia lecture. We already discussed the innervation. So there are three reasons, there are three problems. Body's inherent protection system against invasion of foreign body. So there is a gag reflex in the oral cavity. There is something called glottic closure reflex, which is at the vocal cord level. And if at all, if foreign body pass beyond that, then the cuff reflex will throw it away. And we have to overcome these three things. So if you have to give block, these three blocks are needed for giving successful airway anesthesia. So I'll straight away will take you to the. So glossopharyngeal nerve block can be given through intraoral and extraoral approach. Intraoral approach where at the tonsillar pillar between tongue and base of the tongue and the tonsillar pillar, you need to inject 2 ml of drug on either side. This is very vascular area, right besides a major vessel. So you have to be really careful. This requires quite wide mouth opening, a cooperative patient, and you need to take tongue away to approach that area. So I don't know why do we need to do fiber optic intubation in such a situation. So I routinely suggest that we don't. The oral glossopharyngeal block is routinely not done. You can do extraoral approach, where for the extraoral approach, it is midpoint of angle of mandible and mastoid process. You draw a line, and the midpoint of that is the area where there is a styloid process. You try to identify the styloid process, and once you identify the styloid process, go posterior to that. Once you go posterior to the styloid process, you walk off to the styloid process. That is where the nerve is, glossopharyngeal nerve is. You again need to repeat this block on both the side. And when you do it on both the side, your glossopharyngeal block is there. But glossopharyngeal nerve area can be very easily anesthetized with the surface anesthesia like spray, gel, gargle. So routinely glossopharyngeal block is not that much practiced. Most important thing would be superior laryngeal nerve block. When you give it successfully, vocal cords are actually, you block both the area above the vocal cords, and also you block with the external branch, you block the cricothyroid muscle. And this cricothyroid muscle keeps vocal cord, the work is to adduction. So when you give block, they remain in abduction. So they remain wide apart. So to give superior laryngeal nerve, which comes from above and divides into internal and external branch, right below the superior cornu of a hyoid bone, greater cornu of hyoid bone. So below greater corner of hyoid bone, nerves divides into internal and external branch, and it pierces the internal branch, pierces the thyrohyoid membrane. So this is the area where you can block it. So what you can do is palpate greater corner of hyoid bone, go slightly below that, and that is the area where you can puncture. Again, you have to repeat on both the sides so you can easily identify the lateral most part of a hyoid bone. Touch the bone, walk off, go posteriorly and slightly anteriorly. You can also go directly below the greater cone of hyoid bone straight away. Puncture, you will feel the click. Give 1 ml of drug below the thyrohyoid membrane, and as you are coming out, give another cc. This will block the external branch of a superior laryngeal nerve. You again need to repeat on both the side. For giving anesthesia below vocal cord, you need to give transcricoid injection. People also call it recurrent laryngeal nerve block, but it is not essentially recurrent laryngeal nerve block. You are blocking the surface, you are giving surface anesthesia to the trachea. So you have to go through we prefer cricothyroid membrane. You have to remain in midline of a cricothyroid membrane. Go towards cricoid part as far as possible. We usually use cannula or a vein flow to puncture. Once you puncture, we remove the stellate metal part and keep plastic cannula inside. Remain in midline as near to cricoid as possible. You will feel loss of resistance. You aspirate air, confirm intratracheal position, and then direct cannula to the lower side or the caudally. Again, you confirm the intratracheal presence with the help of aspiration. Ask patient to take deep breath, and at the end of breath, you push the drug. 4 to 5 ml can be pushed. Patient is going to cough. Inform patient that he is going to cough. You are going to cough, and don't worry about coughing. So when you inject, this will give a good intratracheal anesthesia. One important consideration what I wanted to show you was the atomizer technique which we have developed for our own system. So this is what we have developed, a customized atomizer which works for nasal area, oral area, almost up to superior laryngeal nerve. It can be, we can give very good anesthesia. So what we do here, we connect a cannula to a 3-way. Here we have connected it to oxygen tubing, and this area which will connect the drug. You start 10 to 15 liter flow, and it breaks the drug into small particle, and the throw is pretty good, quite good when you give flow of 10 to 15 liter. I'll just show you how much distance these particles can travel. So what I've done initially for the demonstration purpose is I've used betadine solution. I'm just showing you a betadine solution, and see how much distance it is traveling. Almost 1 to 2 feet it can travel. These small particles, small droplets can travel up to 1 to 2 feet. So when you give anesthesia with the help of such an atomizer, it will travel right down to nasopharynx, oropharynx, and our experience says supralaryngeal area is also easily blocked. Only tracheal area, since it is passing through a very narrow area, is not successfully, we are not successful that much. It is not efficient or good anesthesia for the tracheal part. So I'm trying to give, we take 5 ml of drug, 2.5 ml into each nostril. And you see this elderly gentleman, we are trying to do awake video laryngoscopic intubation. I have done awake video. See the oral part, which is very good. The anesthesia patient is really comfortable. I am putting a nasotracheal tube. The tube is guided through the vocal cord. Only while passing the tube inside, patient has some coughing. But patient is really, really comfortable, and you can easily do it. So this is the atomizer, customized atomizer which we have developed. Okay. Anything else anyone would like to know?
There is one more question. How
Yeah.
to sterilize the fiber optic bronchoscope and the channels?
Yeah. So sterilization of a fiber optic bronchoscope is a 4-step process. So one is bedside cleaning. The moment you have finished the procedure, you should do a thorough cleaning of the entire outside surface. Then you should suck saline through the instrument channel so that secretions which you have sucked during procedure is sucked out through the from the instrument. Then you can use alcohol for 5 seconds to dry it up. Now this cleaned fiber optic bronchoscope is taken for the disinfection. For the disinfection, we can use various techniques that include the most important and the most commonly used technique is Sidex solution. Disinfection with the help of a Sidex. So we use 2% Sidex solution, which we have to keep. The immersion should be for 20 minutes and the temperature of the room should be more than 20 degrees centigrade at least for 20 minutes. So you have to disengage each and every connection. Suck the Sidex solution through suction channel. The suction channel is also having a Sidex solution. Immerse entirely, complete assembly into the Sidex solution. Keep it there for 20 minutes. Remove it. Then again, this procedure, entire procedure should be done. You have to clean outer surface, you have to clean inner surface, connect all the attachment, and again suck saline, and finally alcohol solution, so that the inner entire channel is dried, and when the alcohol dries up, entire channel is without any humidity, liquid or any other material. You should do leak test before sending this for the I would say disinfection. So there is a special leak tester is available, which you have to connect it on your fiber optic bronchoscope. Apply the negative pressure. If negative pressure is sustained, that means there is no breach in insertion cord. There is no breach and you can use it. But if leak test fails, that means if the negative pressure cannot be sustained, then you have to send it for the repair, because there is a breach in the insertion cord, which you cannot rectify, you cannot repair by any other means. You have to send it for the repair. So first do leak test, clean up from outside, immerse it in Sidex solution, glutaraldehyde, 2% glutaraldehyde solution for 20 minutes, and then again clean it. That is how you can disinfect the fiber optic bronchoscope. Okay. Hello.
I think there are no more questions. So cleaning is an extremely important part as well, and it should begin the moment we finish our job, so that the lumens are not clogged. And cleaning followed by disinfection.
Yeah, cleaning followed by disinfection.
Well, thank you, Dr. Shah, very much, and Dr. Kosturi Hossain as well. There have been 2 extremely informative sessions. I think the students would benefit immensely, and many of us who are seniors would also benefit from your large experience and the practical tips which are applicable for us always. And I think this indigenous and low-cost atomizer technique that you have demonstrated will see a very fast adoption, and it's an excellent technique, and everything is available with us, ready-made with us. So it's an easy technique to follow.
Yeah.
And other than the trivial part,
one practical tip is when you are using atomizer, you have to really hold syringe well, because when you start 10-liter flow, the pressure is so much that entire plunger will come out. So hold syringe well while you are performing, while you are trying to give drug. Otherwise, entire drug and the plunger will actually, sort of will fly.
Okay, that's an important lesson, I must say. So thank you, Dr. Shah, and thank you, Dr. Kosturi. Excellent presentations, and must be very helpful for all of us and the students. And we expect to have you in future episodes of this ISA WB Star classes. And words are never enough for the time and the effort that you have put in. And good night, everybody. And an excellent session. Extremely enjoyable. Thank you very much.
Thank you. It's our privilege. Thank you very much.
It's our privilege. Thank you, Dr. Palas. Thank you, Dr. Kasturi, and entire team ISA West Bengal. Thank you very much.
Thank you, sir.
We're thinking about going to Ahmedabad this year, but anyway, it's not happening. So.
Yeah, no.
Yes.
Next year, we are going to host next year.
Okay.
Okay.
Good night. Okay. Jyoti, you can go off here now.